Well, everybody, we're going to get started. The House Health Policy Committee will come to order. Would the clerk please call attendance?
Chair VanderWall.
Present.
Representatives Thompson.
Present.
Meerman.
Here.
Tisdall.
Here.
Bierlein.
Here.
DeBoer. Preston. Schmaltz. St. Germain. Bonek.
Here.
Frisbee.
Here.
Whitsett. Carter.
Here.
Whitwer. Neely. Hoskins. Foreman. Mr. Chair, you have 12 members present. You do have a quorum.
Thank you, Madam Clerk.
Freaking me out here.
Whoa, we got a lot of things happening here. Little disshuffled. We're gonna do a couple things a little different. We do have Representative Thompson moves to adopt the minutes of the May 14 meeting. There being no objection, the motion passes. Today we are going to be voting out House Bill 4037 and 4038, as well as taking testimony on House Bills 4218 and 4219, and finishing with 4277. We do have some members that are stuck in some traffic with a pretty big accident, and they're going to be a little bit late, so we're going to amend the agenda and go right into testimony by our Vice Chair, Thompson, on House Bills 4218 and 4219. Representative, I appreciate you bringing these bills forward, and as you make your way to the testimony table, when you're ready, the testimony table is yours. Thank you for being here.
Thank you, Mr. Chair and members of the committee. It's definitely a pleasure to serve on this committee with you. And as you know, I am a nurse, and I'm always going to be a nurse first. So no matter what I do in the legislature, I'm going to have my nurse hat on, and then legislating comes second. So thank you for your time. This package stems from a current investigation from the Auditor General, and it aims to actually improve the oversight and bring peace of mind to families, people, parents, children within the mental health space under the state's care. Because House Bill 4218 would add representatives of advocacy organizations that we actually rely on when we get complaints to our office from family members that are concerned about their patients' care, their loved ones' care. This is the Office of Recipient Rights. And I think it's important to note what that means. Recipient rights. The patient is the recipient of that care. Therefore, we must have transparency and oversight in a department that is there to protect the patient and their family and make sure that their rights are not being violated and that they are receiving quality care. So this would add the Disability Rights of Michigan to the table. It would add ARC of Michigan and the Mental Health Association of Michigan as permanent standing members to the Recipients' Rights Advisory Committee within the Michigan Department of Health and Human Services. Now that is huge because, again, when we have constituents that reach out to our office and they have a concern over a loved one that is in a psychiatric facility, one of the things that I know my office does, and I'm sure in conversations with many of you that your office does, have you reached out to an advocacy group? Have you reached out to the Office of Recipient Rights? So this is a great step forward. This is much needed. The Office of Recipients' Rights is tasked with investigating psychiatric patient treatment complaints. However, I have been made aware of serious concerns with the office's response to these complaints. This is an ongoing issue that we dealt with last term and that we are continuing to work on this term. Disability Rights of Michigan, ARC Michigan, and Mental Health Association in Michigan all work directly with the people that they serve, the Office of the Recipient Rights, and they will bring an important perspective to actually improving these policies and the effectiveness of this office. It will also prohibit any MDHHS executive office staff from being appointed to or serving on this advisory committee, as the current director has appointed individuals from her executive team to this body, which has raised red flags. Now, I'm going to use a pretty dramatic scenario. But the reality of a department investigating itself is if your loved one was harmed by an individual, was sexually assaulted by an individual, would you want that individual investigating the case? No, you would not. So this is the importance of a department not investigating itself. Now, House Bill 4219 would require that hospitals give voluntary hospitalized psychiatric patients written notice of their rights. That's another thing that as a nurse I find very problematic. So a patient has a bill of rights. This is very well posted in hospitals, very well posted in our state facilities. Many patients don't know their bill of rights. So in the mental health code currently, a patient that is involuntarily committed to a facility is given their bill of rights, their list of rights, so that they know what their rights are. Now, they're involuntarily committed. On the other side, you have patients that have chosen to voluntarily seek treatment. They're not afforded that same right. That makes no sense. So they would receive their rights, but not only writtenly, but orally, because we know when someone is in a fragile state of mind, maybe they're anxious, maybe they're having panic attacks, maybe they've made that choice to seek treatment, they need to know in written form and in oral form. Should they choose to discontinue treatment, they have the right to do so. And that is going to allow them to be more relaxed, more acceptive of the care, because they know that they don't want to have the fear of them speaking up and, oh my goodness, if I say, I really don't want to be here, I want to end my treatment, I feel like I made a mistake, which they have the right to do, that they would be retaliated against, and then they would be involuntarily forced to stay. So hospitals already required to give involuntary hospitalized psychiatric patients written notice of their rights. However, the same is not true for patients who sign paperwork agreeing to formally, voluntarily admit. In many cases, this applies to parents who commit their children to psychiatric care. So what that means is because they are the parent and they are the guardian, they are making that choice to voluntarily commit their child, which again is different than the involuntary. I think this is really important. I'm very excited that we have these advocacy groups here today to talk to you. I urge your support on this legislation. I think that it is a very important first step in addressing some of the shortcomings that we see within the mental health field, and I know many of you have spoken out and want to be a part of that conversation. So I open those conversations to you, and I will open for any questions that you may have. Thank you very much.
Thank you, Representative. Any questions from the committee? Seeing no questions right now, we'll bring up I believe, are the next two coming up together. Is that correct? Mary Ann Huff, Mental Health Association, and Simon Zagata, Disability Rights of Michigan. Welcome, both of you. If you take a seat, when you get ready to testify, just make sure your red light is on, and the testimony table is yours.
Okay. Well, good morning, everybody, and thank you for the opportunity to testify today on these two very important bills. Mary Ann Huff, Mental Health Association in Michigan, you have my testimony in front of you, but I'm not going to read it verbatim to you. First of all, great time to be doing this since May is Mental Health Month. And, as an organization that has been around since 1936, incorporated in 1937, one of our primary missions has been to make sure that people who receive mental health services get quality mental health services and supports. And as I indicated in my written testimony, the reason we exist is because of a guy named Clifford Beers, who was a Wall Street stockbroker. Back in the late 1800s, early 1900s, he had some nervous breakdowns and found himself in a couple of public and private asylums, as we used to call them back in the day. And in his book, A Mind That Found Itself, he details his experiences in those asylums, which were not very pleasant. So part of what we do in our association is we really try to make sure that anybody with a mental health condition or a substance use disorder, regardless of severity of condition, have quality treatment. The final thing that I want to say is that, and this is a little history too, there was a time when we did not treat people with mental health conditions very well. And there was a time when a person, a husband or someone could take another person to the superintendent of the state psychiatric hospital, excuse me, in our state. And of course, at that time, state psychiatric hospitals were sprawling. They were like little communities. They had their own dairy farms. But they were built in accordance with what was called the Kirkbride Plan, and it was a good model, and then they became overcrowded. And of course, we also didn't have treatment, real treatment for psychosis, till the invention of Thorazine in 1952, which came to the United States in 1954. I bring all this up to say that even though it's 2025, we still have incidences in both public and private psychiatric hospitals where people are not always treated really well. And that's why particularly House Bill 4219, which gives formal, voluntary individuals, people who say, yes, I think am a person requiring treatment, I need to get inpatient psychiatric treatment, written notice of their rights, because that wasn't happening. There was a story last year. We did a webinar. Simon, Disability Rights Michigan, was part of that with MHAM, with Heather Catallo from WXYZ TV in Detroit, talking about a hospital on the east side of the state that was not giving people appropriate notice. So appreciate the opportunity to be here today, and I'm going to turn it over to Simon.
Thank you, Marianne. Good morning, everyone. Thank you for being here, even though you have to be. I'm excited to have the opportunity to talk to you all this morning. My name's Simon Zagata. I'm here on behalf of Disability Rights Michigan to support bills 4218 and 4219. Disability Rights Michigan is the private, nonpartisan nonprofit tasked with protecting and advocating for the rights of disabilities, or people with disabilities in the state of Michigan. We are a law firm. We provide information and referral, investigation and advocacy, and legal support for people with disabilities in Michigan free of charge. I'm here today because I'm the director of our community and institutional rights team. And my team investigates and advocates for people in institutional settings, like psychiatric hospitals and nursing homes. Over the past few years, our work has really focused on the rights of people hospitalized in psychiatric hospitals. I want to start from a place that we can all agree with, and that's that knowing your rights, no matter the situation, is essential. And I want you to try, even though it might be impossible, to put yourself in the shoes of someone seeking inpatient hospitalization. This is a mental health crisis. This might be one of the lowest points of that person's life, one of the hardest points of their life. It might be late at night. Upon getting to the hospital, they may get medication that is meant to sedate, calm them down, causes extreme fatigue, trouble concentrating. And it's in that scenario that these formally voluntary patients are given the verbal notice of their rights. It's hard to remember verbal information. That's why today we submitted written testimony and we're speaking. And it's even harder when you're in that crisis scenario. And the situation we see with our clients, and my advocates on my team see with our clients time after time, is they check themselves into the hospital and then they don't know how to get out when they are ready to leave and continue treatment outside of the hospital. In Michigan, the mental health code, if you sign in voluntarily, you're required to sign out, to sign an intent to terminate treatment form. And we've heard from patients time and time again that they didn't know they had to do that. And so they ask to leave, and the hospital says, no, or you're not ready. And then the patient does not know what they need to do to dispute that, or what their rights are when they do dispute that. And that creates a barrier to care, which I think is the point that is most important to remember here. We do not want barriers to people seeking this very important care at these crisis moments. And it is a barrier to have confusion about your rights, to think that you might be held without knowing why, and to not know what you can do or what the laws are around it. And so that's why we support this written notice of rights. We think it's extremely important to make sure everyone's on the same page. There's no question of what was said or if there was an interpretation of the rights. And there's no question of if they got their notice of rights in the first place, because they got it on paper, they got the intent to terminate treatment form, and they can review it later at a time when the crisis has abated. And so we're excited to be here to support House Bills 4218 and 4219, and I'm available for any questions and appreciate the opportunity to testify.
Thank you both for being here. Committee, any questions? I did have one. Oop, who do we have? St. Germain. Representative St. Germain.
Thank you, Mr. Chair. I'm just curious, because I know of, I had a loved one go through a similar situation. Do you think, say when a patient is admitted or voluntarily or not voluntarily admitted to a hospital, and let's just say they have good health insurance, do you think they purposely sometimes want to keep that patient just to milk the health insurance?
I think I can answer that. I find that hard to believe because one of the complaints that we have sometimes in our organization is that sometimes people are not hospitalized long enough. Sometimes they just seem to get somewhat stabilized and then they're sent back into the, into the world. And I think it kind of goes either way, to tell you the truth. When I get calls from folks, from families primarily, it's either they didn't keep my loved one long enough, or sometimes they kept them too long. At the insurance level, too, there's the utilization management folks who look at the length of stay, too. So there's a whole lot of factors that go into that. I guess if I'm hearing what you're asking is, do you think it's possible that people are kept longer to bill insurance than they need to be? And I don't know if that's true or not.
Representative Thompson.
Thank you, Mr. Chair. Thank you. This question could be for either one of you. If anyone has concerns over will this make it too easy for patients that have voluntarily committed themselves, that may be at risk to themselves or others, from removing themselves from the facility that they're at, because we know that they already have the right to end services. Can you talk a little bit more about how clinicians will still play a role in the safety and the education of their condition, and this is not going to change that with that patient?
Yeah, thank you for the question. It does not change the process at all. And the process is still, you need to fill out that intent to terminate treatment form. Once a patient fills out that form, the hospital has 72 hours to evaluate the patient and either say, yes, patient, you're right, you do not meet criteria for involuntary inpatient hospitalization. We are going to discharge you to treatment in the community. Or if the physician disagrees, they can start the probate court process to keep the person involuntarily. And so that still applies, doesn't change that. There's still that check on patients checking themselves out.
If I may, Mr. Chair?
Absolutely.
When we talk about the bill that places your organizations on an advisory board for the Office of the Recipient Rights, out of all the phone calls that you get from the community reaching out to you for advocacy, what is one of the first things that you ask that person that contacts your office? What is the first question you ask them, have they done, usually?
Yeah, thank you, Representative. And I think I know what you're getting at, and you're right. It is, have you reached out to recipient rights, if recipient rights applies to that situation? Have you reached out to licensing, other enforcement entities about the issue you're having?
Thank you. Thank you very much.
Any other questions from the committee? I do have one question. I just, under these bills, somebody goes through treatment in a hospital, et cetera, they go to a secondary facility. Do these rights still carry on until they're deemed okay? How long does this stay intact?
Yeah, thank you, Representative. Yes, and this applies specifically to facilities covered by the mental health code. So psychiatric hospitals, and of course this involves hospitalization, so that would be where this would apply, and those rights remain intact. Of course, anytime someone's receiving mental health treatment, this just changes that notice requirement at a psychiatric hospital.
Very good. Representative Carter.
Thank you, Mr. Chair. I'm not sure if this question is appropriate, but the patient's bill, mental health bill of rights, what happens if a patient is incoherent, where they can't read or sign a document? How is that handled?
Yeah, Representative, I think that's a very appropriate question, and I thank you very much for considering that, because accessibility is going to be key. This bill mandates written notice of rights, but you're right, that is not accessible for everyone. And so it will be very important for people to receive their rights, that if they need it read to them, or if they need it reworded, if they need it in a different language, that's provided, so there's actually access, and it's not just a check in a box that we gave them the papers, we're good.
Absolutely.
Thank you for that. But I think I was pointing more towards if you have a individual who is in crisis, that you may have to restrain, make a judgment call. How is it handled in those cases?
Yeah, thank you. I think that just makes it all the more important to have it written down and placed in their room, making sure a copy is accessible to them once that crisis has passed. Because we don't want someone, for example, yelling above a restraint situation, someone's rights at them. So I think that just makes it more important. Thank you.
Representative Thompson.
Thank you. If I may talk a little bit about that, not in the question form, but I think you started to hit on what your question was, and I totally understood what your question was. So at the moment of crisis, they would not be able to check themselves out. Like, it would not change that. There could even be a moment if that level of crisis never changed in 72 hours, and maybe they do need to speak with family about getting some type of guardianship. That would never change that. This is just if they're in a crisis situation and they have the ability to calm down. So when these rights are given to them, and they are given, a Xanax or medication or a benzodiazepine or tranquilizer, that they're not understanding. They're in a state of delirium, so they can't process what their rights are. So when they come out of that and things are calm, then they will understand their rights. And it doesn't change the fact if they were at risk or they were confused and disoriented or not alert and oriented. All the laws would still apply. The doctor would still have the ability to say, you need to be here, contact the family. So we're not trying to do that. We just want to make sure that they have the same rights as people that are involuntarily committed. So thank you. Good question.
Any other questions? Seeing no other questions, thank you both for being here and giving up a little of your time with this beautiful weather that we're having out, so be careful on the roads. We do have some cards to read in on these bills. Not wishing to speak in support of both bills, 4218 and 19, Senator Weber. Not wishing to speak in support of both bills, Christine Scheer, Michigan Association of Health Plans. Not wishing to speak in support of both bills, Sherry Boyd, the ARC of Michigan. Not wishing to speak in support of both Danielle Serrani, Michigan County of Social Services. And Shane Burton, not wishing to speak in support of both bills. And that's all the cards that we have. Thank you, everybody. With that, we will move on. We're still waiting for one member, so we're going to move right on to Representative Bierlein in his testimony on House Bill 4277. And welcome, Representative. You've been through the drill a few times, so as you know, when you get to the testimony table, if you hit the red button, the floor is yours, and we look forward to your testimony. Thank you for being here.
Well, thank you, Chair VanderWall and members of the committee for the opportunity to speak today in support of House Bill 4277. In some states, when medical professionals apply for a license or renew an existing one, they are asked to provide a range of information, including their educational background, criminal history, and in some cases, questions related to their physical and mental health. While these questions are often well-intentioned, particularly when it comes to protecting patient safety, they can have unintended and serious consequences, especially when they dive too far into a person's individual medical history. They've required individuals to disclose specific diagnoses, treatment history, and conditions stretching back many years. The stated purpose behind these questions is to protect patient safety. However, the unintended result is that these questions have actually discouraged medical professionals from seeking the mental health care they need. The reality is that many in the medical field chose not to get help for treatable mental health conditions because they fear it will endanger their license or compromise their careers. And when caregivers suffer in silence, the risk to patient care grows, not because they sought treatment, but because they didn't. In other words, the very questions intended to promote safety can actually do the opposite. I do want to be clear, invasive mental health questions like these are not currently found on Michigan's licensure application. And that's a good thing. And what we're trying to do is make sure it stays that way. This concern was brought directly to my attention during conversations with physicians in my district over the last couple of years. This is actually a reintroduction of a bill that I had last term. Local providers expressed to me that the fear of such questions being added in the future is real, and I think you're going to hear from some of them testifying after myself. House Bill 4277 addresses these concerns directly by amending the Public Health Code to ensure that only two narrowly tailored appropriate questions can be asked on license and renewal applications. The first is, do you have any reason to believe that you would pose a risk to the safety or well-being of a patient or client? And the second is, are you able to perform the essential functions of the health profession for which you are seeking a license, registration, or renewal without reasonable accommodation? These questions are carefully crafted to balance public safety with the personal privacy of the applicant. They focus on current ability to practice safely and completely. This approach reflects national best practices and legal standards across the country. So ultimately, the bill does two important things. First, it gives healthcare professionals the confidence to seek help when they need it without worrying that doing so could jeopardize their ability to serve in the future. And second, it helps ensure that professionals who treat Michigan patients are healthy, focused, and supportive. This bill is a common sense preventative measure that strengthens the integrity of our licensing system, protects patient safety, and supports mental health amongst Michigan's healthcare workforce. So thank you again for the opportunity, and I'm happy to answer any questions.
Thank you, Representative. Any questions from the committee? Seeing no questions, thank you very much for being here. I believe next up we have Brittany Taylor. Welcome. Thank you for being here and representing MSMS. And the testimony table is yours, and we appreciate what you have to say today. Thank you.
Thank you so much for having me here today. My name is Dr. Brittany Taylor, and thank you so much for the opportunity to submit testimony on this urgent issue of physician burnout and the role of Michigan-specific policies that play in compounding this crisis. I'm a double board certified internist and pediatrician, and I provide primary care in Flint, Michigan. My patients span the entire, all ages, all backgrounds, many with very complex medical and social needs, and I deeply love the work that I do. But myself, like many other colleagues, am being pushed to the edge by a system that really no longer allows us to focus on what matters most to us, patient care. When we discuss physician burnout, there's a question that often arises, sometimes voiced directly, sometimes just implied. Every job is demanding, everyone faces stress. What makes doctors different? Why can't they just deal with it? It's a really fair question, and it deserves a real answer. What makes it different is that physicians are uniquely burdened. It's a culture of medicine that expects us to carry that burden in silence. Vulnerability is often seen as a weakness. And in this profession, weakness can carry professional consequences. Burnout doesn't just mean being tired or overworked. For physicians, it's the emotional weight of making life or death decisions every day with little or no room for error. It's moving from one patient's tragedy to another's routine checkup without pause. It's being expected to remain composed and capable no matter the grief, the fear, or the personal toll. And when that toll becomes too great, the system is more likely to penalize us than support us. The statistics are staggering. Physicians in the U.S. face significantly higher rates of depression than the general public. Nearly 28% report major depressive episodes. The rates are even higher among women and physicians from underrepresented racial and ethnic groups, often facing additional stressors like discrimination, systemic bias, and the constant balancing act between professional demands and family responsibilities. As a physician, I've seen colleagues, particularly women, step away from clinical practice, not because they lack the skill or the dedication, but because they were overwhelmed and under-supported. Of bright, compassionate doctors leaving medicine early in their careers, and we're left wondering, could this have been prevented? Burnout hits every corner of our profession. Anesthesiologists, psychiatrists, and surgeons are some of the specialties at greatest risk. But the truth is, nearly half of all physicians in the U.S. report at least one symptom of burnout, either emotional exhaustion, a sense of detachment from patients, or a feeling like their work no longer makes a difference. Despite the evidence, many physicians still hesitate to ask for help, not because they don't recognize the need, but because they fear the consequences. In some states, doctors are still asked to disclose a personal history of mental health when applying or renewing a license. That is not the case in Michigan today, and that's something to be proud of. Our current licensing process respects physicians' privacy and reflects a more modern understanding of mental health. But those protections are not guaranteed. Licensing language can be changed administratively without a legislative input. Future leadership or departmental changes could shift this direction drastically. And the truth is, as long as physicians feel unsafe disclosing their struggles or seeking care, even in a state like ours, the culture of fear will remain. This is why House Bill 4277 is so important. It codifies these protections into law, ensuring that Michigan physicians can seek mental health care without fearing that doing so might one day jeopardize their ability to practice care here. It isn't about criticizing our licensing board or casting blame. It's just about creating a long-term and structural reassurance. Physicians need to know they're protected not just now, but in the future. Even when physicians try to seek help, it's not always accessible. We're just talking about this. Mental health provider networks are often inadequate. Insurance coverage is inconsistent. Wait lists are very long. It's difficult to find the right provider, particularly as a physician. And when care is delayed or denied, the consequences are profound. Physicians have one of the highest suicide rates of any profession. And the most devastating statistic, female physicians, like myself, are 2 to 6 times more likely to die by suicide than women in the general population. The numbers should stop us in our tracks. It's not an isolated issue, it is a crisis, and we must change course. We cannot let outdated stigma or policy ambiguity prevent physicians from getting the help that they need. We must stop framing help seeking as a weakness. We must recognize the connection between physician well-being and patient care. This is why I urge you to support House Bill 4277. Yes, Michigan is already doing better than many other states, but let's not leave that to chance. Let's make it clear in statute that we believe physicians deserve the same access to care and protection as anyone else. Let's build a culture that where seeking help is not a liability, it is a sign of strength. This is an opportunity for Michigan to lead, not just in setting a high standard of care, but also in creating a system that supports the longevity and the health of their workforce providing it. Physician burnout is not a personal issue, it is a systems issue. And this is one system we can and should improve now. Thank you.
Thank you. Committee, any questions? Representative DeBoer.
Not really a question, but I think one good thing that came out of COVID is the realization that anyone who serves the public goes through a lot of emotional weight in their lives. And, I as a former mayor in our city, we introduced a mental health organization to work with our police. Because just as they walk away from some horrific scene and then they're supposed to handle a speeding ticket down the road. And there was no processing, no time for that. And they go home to their families and they carry burdens of so many other situations. And the same is true in your profession. I really think we need to stop and think about everyone that serves the public carries their own burden as well. And I just really respect your choice of profession, your willingness to go through all these things. And I cannot imagine the emotional pressure of the whole COVID situation in your profession in carrying the health of the public. And I just wanted to say I really appreciate it and respect it. And I think we should do what we can to support you. Thank you.
I really appreciate that. I worked in my residency in New York City during the COVID pandemic, and I worked in the ICU the entire month of March, April, and May. So it was an exhausting experience and definitely changed my course, and I really appreciate that, so thank you.
A friend of mine, a female physician, spent the weekends in that New York thing and then came back and tried to, carry her practice, and yet no one knew the stresses. A lot of us were just in the basement. As you handled the world. So thank you.
Thank you. Seeing no other questions, appreciate your time today. Thank you. Oops, I'm sorry. Missed you, Representative Preston.
Thank you, Chair. Thank you for your testimony. I can completely relate. I guess my question is this. Thank you to you and your peers for everything that you do. But my question is this. Would you support something similar to this to other layers of the healthcare profession?
100%. I mean, my brother's a nurse and my aunt is a nurse practitioner, so I know that they carry the weight of the burden just as much as I do. Like I was talking about when I was in the COVID wards, we would go in and we would flip. The only thing we could do is just flip the patients pretty much every 3 hours, and there was one nurse that was with me the entire time, and I know how much she struggled as well with that, and so I would definitely think that was important for all other health professions as well.
Thank you.
Thank you very much. Appreciate it. Next up, we have joining us via Zoom Dr. Stephanie Simons, the Chief Medical Officer for Dr. Lorna Green Heroes Foundation. Welcome. Whenever you're ready, if you can unmute yourself, the testimony screen, I'll say, is all yours.
Thank you very much. Good morning. I've been a licensed physician in the state of Michigan since 2003. I'm a board-certified emergency medicine physician after completing my undergraduate medical school and residency in Michigan, and I currently serve as the Chief Medical Officer for the Dr. Lorna Breen Heroes Foundation. Lorna Breen was a physician in New York City during the pandemic who died of suicide after expressing to her family that she was terrified after receiving mental health care for the emotional, intellectual, and physical exhaustion that she experienced during her care, that she would be unable to provide care because of licensing and credentialing concerns. Now, it turned out at that time, the state of New York didn't ask about a history of mental health on their licensing application, but Lorna didn't know that. And And so the Lorna Breen Heroes Foundation was started with a dedication to the mental health and well-being of the healthcare workforce, and helping to improve the transparency of the licensing and hospital credentialing process for healthcare workers. So I'm joining you from Ann Arbor, where I live, and I appreciate the opportunity to attend this hearing remotely so that I can fulfill my other duties this morning. I strongly support Michigan House Bill 4277, which seeks to codify the removal of mental health related questions from this state's health professional licensing applications. This reform is essential for fostering a transparent and sustainable healthcare workforce in Michigan. Transparency is the essential word here, and it's worth noting that although we currently don't ask about a history of mental health on Michigan licensing applications, it's currently impossible for licensee to access those applications and view those questions ahead of time to understand what will be asked. So codifying the elimination of these questions enhances the economic certainty for physicians and other healthcare workers in choosing to receive mental health care, because the process of training that goes into licensure is a significant investment. And any ambiguity about the qualifying process can deter people from entering or remaining in preventative counseling or therapeutic mental health care. By providing clear and consistent guidelines, we empower physicians and other clinicians to make informed career and financial decisions without the fear of unexpected barriers, and encourage clinicians to practice in medicine. The Lorna Breen Foundation sustains a map of states and that have licensing applications consistent with best practices. And because I'm a licensed physician, I've been able to access the medical license, but we also haven't been able to clarify and confirm for nurses, dentists, or pharmacists what this looks like. And in answer to the previous question about whether this is important for all licensed healthcare workers, it absolutely is. And we work together in teams, and the whole teams need to be healthy. Evidence from other states supports this approach. In Mississippi, the State Board of Medical Licensure transitioned to an attestation model, removing the requirement for physicians to disclose mental health diagnoses on licensing applications. And this change was to reduce stigma and encourage healthcare workers to seek necessary mental health support without fear of professional repercussions. They didn't just make the change, but they featured this change on their website, including media outreach aimed at healthcare workers. And Mississippi saw an increase of 15% in physicians self-reporting for mental health care. It's the communication and the transparency that's essential even after the changes are made. Transparency in the licensing process is crucial for healthcare workers, not just physicians. By codifying the removal of mental health related questions, Michigan would align with best practices that promote secure practice and support for the healthcare workforce. This change would encourage professionals to seek help when needed, ultimately leading to a healthier, more resilient healthcare system for patients and for healthcare workers. Passing House Bill 4277 would not only reduce stigma and encourage mental health support among healthcare professionals, but enhance economic security by increasing transparency in the licensing process. A healthier, more secure healthcare workforce improves access to care for Michigan residents. And I don't only have a license in Michigan, but family in Michigan, including my own, who are potential patients. So I encourage lawmakers to support this important legislation for the benefit of our healthcare workforce and the communities they serve. And thank you for the opportunity to testify, and I'm happy to answer any questions.
Thank you for your testimony. Representative Thompson has a question.
Thank you, Mr. Chair. Thank you for your testimony. I really am supportive of this legislation, so I don't want you to get the wrong idea. But one of the things I think people on the opposite side that may be opposing this may worry about the safety of the patients that they're caring for if they weren't to disclose a diagnosis. So can you tell the committee some things and checks and balances that are already in place in facilities that would protect a patient if a healthcare worker or a physician were to be deemed as incompetent or having some sort of condition that would affect their ability to care for a patient?
So I think it's important to recognize that the questions of sort of impairment or competence to care for patients remain. What we're asking to be codified into law is that we're not asking look-back questions on diagnosis or treatment of mental health care. So for instance, if someone like myself experienced postpartum depression during pregnancy, there is no reason why that would continue to impact my ability to competently and ethically practice medicine. It's what we call in my house a nunya question, right? Like it's nunya business about my personal past medical history and mental health history. It doesn't impact someone's ability to practice ethically and soundly, and asking really stigmatizes mental health care. It's worth recognizing that often on applications, these questions are asked along with a history of felony convictions or pedophilia. One of these things is not like the other, and having a mental health condition or seeking treatment for a mental health condition is a sign of strength in a healthcare worker. Additionally, asking these questions does not reduce the incidence or prevalence of mental health conditions in the healthcare workforce. It only reduces the number of people who are receiving care. So healthcare workers are faced with a decision to make when they develop a mental health condition. And keep in mind, that may just be, I think I could benefit from therapy, okay? Like so many of us could. They have to make a decision. Do I economically put myself and my family at risk because of unclear professional ramifications of seeking mental health care? Or do I make do and remain untreated? Or do I seek care and then be faced with a decision about whether or how I should answer that question on a licensing or credentialing application? So we're not increasing the number of healthy healthcare workers by asking these questions, and we're not decreasing the number of people with mental health conditions. We're just increasing the number of people with mental health conditions who don't receive care. At the state level, for healthcare workers who become impaired, there's a professional health program that serves as a monitoring and treatment program for healthcare workers that monitors their fitness to return to duty. And many hospitals and health systems within the state have additional resources for healthcare workers. It's worth mentioning that questions about a history of mental health care are not only found on licensing, but also on some hospital credentialing applications, although these are increasingly being changed as well in the recognition that asking actually increases patient risk as opposed to protecting patients. So, you know, it's recommended that healthcare workers either positively attest to self-care or that they have to attest that they are lacking impairment to care for patients.
Thank you. Appreciate it. Any other questions from the committee? Seeing none, I want to say thank you for being here today and taking some time out of your busy schedule. We appreciate it, especially on this important issue. So you have a great day.
Thank you.
We have a couple cards to read in. Not wishing to speak in support of the bill, Adam Carlson, Michigan Health and Hospital Association. Christy Snitchen, Michigan College of Emergency Physicians, not wishing to speak in support of the bill. American Association of Nurse Practitioners, not wishing to speak in support of the bill. Thank you, everybody. We now are going to go to the beginning of our agenda earlier. We appreciate everybody making it here safely today. We know that it's been an ugly weather day, and appreciate everybody making it. We're going to go to bills 4037 and 4038. Not wishing to speak. In support, Youssef Rabi, Michigan Nurses Association. Not wishing to speak, opposing the bill, Sharday Burton, Department of Health and Human Services. With that, we need to adopt an H1 sub for House Bill 4037. Most of these changes come from the correspondences with the department. Representative Meerman moves to adopt the H1 substitute. Clerk, would you please call the roll?
Chair VanderWall,
Yes.
Representatives Thompson,
Yes.
Meerman,
Yes.
Tisdall,
Yes.
Bierlein,
Yes.
DeBoer,
Yes.
Preston,
Yes.
Schmaltz,
Yes.
St. Germain, Bonak,
Yes.
Frisbee,
Yes.
Witsit, Carter,
Yes.
Whitworth,
Yes.
Neely, Hoskins,
Yes.
Foreman. Mr. Chair, you have 14 yeas, 0 nays, 0 pass. The motion prevails.
Thank you, Madam Clerk. Now we need to adopt amendment brought forward by Representative Preston. Representative, would you like to speak to your amendment?
Thank you, Chair. My amendment just simply adds a transparency aspect to this that I think is desperately needed for the patient to know which facilities and which institutions have been accessing their record. It has a 6-year time frame where the patient will be able to make a query to the health data utility, basically disclosing all entities that have accessed their information for a period of 6 years upon request.
Excellent. Thank you, Representative. I am assuming, Representative, you will move your amendment. Would the clerk please take the roll?
Chair VanderWall,
Yes.
Representatives Thompson,
Yes.
Meerman,
Yes.
Tisdall,
Yes.
Bierlein,
Yes.
DeBoer,
Yes.
Preston,
Yes.
Schmaltz,
Yes.
St. Germain,
Yes.
Bonak,
Yes.
Frisbee,
Yes.
Witsit, Carter,
Yes.
Whitworth,
Yes.
Neely, Hoskins,
Yes.
Foreman. Mr. Chair, you have 13 yeas, 0 nays, 0 pass. The motion prevails.
Do we have 14 left?
Yes, sorry, 14. 14 yeas, 0 nays, 0 pass.
It's early in the morning, Hazel. We understand.
Sorry.
Thank you, Madam Clerk. The amendment is adopted. Now Representative Tisdale moves to report House Bill 4037 to the floor with recommendation. Clerk, would you please call the roll?
Chair VanderWall,
Yes.
Representatives Thompson,
Pass.
Meerman,
Yes.
Tisdall,
Yes.
Bierlein,
Yes.
DeBoer,
Yes.
Preston,
Yes.
Schmaltz,
Yes.
St. Germain,
Pass.
Bonak,
Yes.
Frisbee,
Yes.
Witsit, Carter,
Yes.
Whitworth,
Yes.
Neely, Hoskins,
Yes.
Foreman. Mr. Chair, you have 12 yeas, 0 nay, 2 pass. The motion prevails.
Thank you, Madam Clerk. 4037 is reported with recommendation. Next up, we have House Bill 4038. Representative DeBoer moves to adopt the H1 substitute for House Bill 4038. Clerk, would you please take the roll?
Chair VanderWall,
Yes.
Representatives Thompson,
Yes.
Meerman,
Yes.
Tisdall,
Yes.
Bierlein,
Yes.
DeBoer,
Yes.
Preston,
Yes.
Schmaltz,
Yes.
St. Germain,
Pass.
Bonak,
Yes.
Frisbee,
Yes.
Witsit, Carter,
Yes.
Whitworth,
Yes.
Neely, Hoskins,
Yes.
Foreman. Mr. Chair, you have 13 yeas, 0 nay, 1 pass. The motion prevails.
Thank you, Madam Clerk. The H1 substitute is adopted. Representative Bierlein moves to report House Bill 4038 to the floor with recommendation. Would the clerk please call the roll?
Chair VanderWall,
Yes.
Representatives Thompson,
Pass.
Meerman,
Yes.
Tisdall,
Yes.
Bierlein,
Yes.
DeBoer,
Yes.
Preston,
Yes.
Schmaltz,
Yes.
St. Germain,
Pass.
Bonak,
Yes.
Frisbee,
Yes.
Witsit, Carter,
Yes.
Whitworth,
Yes.
Neely, Hoskins,
Yes.
Foreman. Mr. Chair, you have 12 yeas, 0 nay, 2 pass. The motion prevails.
Thank you, Madam Clerk. House Bill 4038 is reported with recommendation. Before we close out Healthcare, Health Policy Committee today. I do want to welcome all the guests that we have, the graduate medical education residents that are here visiting on their Advocacy Day. Thank you for taking some time and sitting in on committee. And thank you all, and best wishes as you continue your education. And we look forward to you helping us in the healthcare system. So thank you for being here today. Representative Hoskin moves to excuse absent members. There being no objection, the motion prevails. There being no further business before the committee will stand adjourned.